Welcome everyone to Aspiring Mentors free webinar session. Just to give you an insight about Aspiring Mentors, we are the first free USMLE mentorship and tutorial organization. And currently we are helping students preparing for the USMLE Step 1, Step 2 CK, OET, and also Step 3. And we are currently functioning internationally. So our today's webinar will be discussing on high-yield biostatistic topics that's custom for USMLE exams. And our presenter is Dr. Shourya. Dr. Shourya is an international medical graduate from India, and also he's a mentor at Aspiring Mentors. So just few meeting points that we'll have today is we'll be accepting questions at the end of the presentation. So please mute yourself. So without further ado, please welcome Dr. Shourya.
Thank you for that introduction, Dr. Metlet. It's nice to be here. So we'll be starting with the biostats review. It's a very short review, but then we have tried to incorporate most of the important topics that I feel it's very essential to know if you're taking USMLE Step 1 or USMLE Step 2. So without further ado, we'll start with the presentation. All right. Okay, so okay. So biostats is a very high scoring topic on your USMLE Step 1 and Step 2 exam, and maybe even on USMLE Step 3. It's very highly tested, and if you know these basic concepts, I think it's a very great opportunity to get most of these questions right. So we have to start with the 2x2 table. Now, the first thing you should know is how to design a 2x2 table and what is the importance of the 2x2 table. Now, 2x2 tables are your first peek at the question. So if the question includes a 2x2 table, by looking at it, you'll get a rough idea what is the question is all about. But if the question does not include the 2x2 table, then I would urge you to create a 2x2 table. In doing so, you'll be able to easily answer the question, okay? So here you have the disease or outcome on top, and then you'll have the exposure or intervention on the left side of the table. So you can use the mnemonic DOT. So disease and outcome on top, or the mnemonic lie. So on the left side, you'll have intervention or exposure. Another way to remember this is that the dependent variable goes on top. So what do I mean by dependent variable? So let's take an example. So suppose smoking is causing lung cancer. Okay. So if smoking is causing lung cancer is somewhat dependent on smoking, right? So this is your dependent variable. On the other hand, smoking is independent. It does not depend on lung cancer. Anybody can smoke, right? So this is your independent variable. So smoking as being your independent variable, it will go on the left side here, and on the top, your dependent variable will go. All right. So here we go to the next slide. Okay, here we have 4 letters, letter A, B, C, and D. So if the disease or outcome is present and the exposure or the intervention is also present, then we have the letter A for that. If the disease is not present, but the exposure or intervention is present, then we have B. If the disease is there or outcome is there present, but the exposure and intervention are not present, so that is your C. If both the disease and the exposure or the outcome and intervention both are absent, then you will have the letter D. So you will see the formulas mentioning like A times T divided by B times C, or A upon A plus B divided by C upon C plus D, like this. So you'll have to remember like what are the particular position of the letter. Okay, so It's fairly easy, right? Whenever you read a text, what do? You go left to right, and then you have to go to the next line and then again go left to right. Like this way, you have to start with A and then to the right B, then you go to the next line, there's C, and then you go to the right, there's D. So this is how you construct the 2 by 2 table. Okay. So we'll first talk about the odds ratio. Now, odds ratio, it is mostly used in the case control studies. Okay. So how do you remember? So I think you all know about case control studies and cohort studies. So you have to look at the penultimate letter. Okay. So here the penultimate letter is O. So that means odds ratio is used in case control. But if you talk about cohort studies, then the last letter is R. So that means you have to use relative risk, but more on relative risk later. So what is the definition of odds? It is the probability of an event occurring divided by the probability of this event not occurring. Okay. So you might ask, what is the difference between probability and odds? So let me give you an example. Suppose you are rolling a dice, and whenever you roll a dice, you can get 6 digits, 6 numbers you can get. So what are the chances that you can get either number? So suppose you want 6, you want to roll a 6. And after you roll, there's a probability that you can get 6 1 out of 6 times. Okay, because there are 6 sides. But odds is different because the odds of rolling a number 6 is 1 by 5. Why? Because for calculating odds, you have 2 outcomes. Favorable outcome, that is rolling a 6, and rest are the non-favorable outcomes. So those are your 1, 2, 3, 4, and 5. So there are 1 favorable outcome and 5 non-favorable outcome. So the odd becomes 1 upon 6. Okay, so that is what basically the odd is. And it's not same as the probability. Okay. So whenever you're calculating the odds ratio, what you're basically asking is that what are the odds that the affected population had the exposure versus the non-affected population who had the exposure. So we'll see an example. Okay, so first, the formula for odds ratio. To calculate it, you have to know the odds of exposure in individuals with disease and the odds of exposure in individuals without disease. So this is, first one is the case group, second one is the control group. So how do you calculate it? It is the exposure in individuals with disease divided by no exposure in individuals with disease. So see, odds of exposure in individuals with disease talks about only the diseased portions, disease positive part of this 2 by 2 table. So which column be that? This one, right? This column is the one with disease. Okay. So A upon C, because exposure in individuals with disease upon no exposure in individuals with disease. Then we talk about odds of exposure in individuals without disease. Okay. This is the control group. So exposure in individuals without disease upon no exposure in individuals without disease. So this is the other column you're concerned about. Okay, so that is B by D. Now for the ratio, for calculating the ratio, you need to simply divide this one with this one. So you have to do A by C divided by B upon D. Okay, so you simplify it, it comes like A times D divided by B times C. So that is your basically the odds ratio. So here we have an example. I want all of you to make a 2 by 2 table along with me so that you have a better grasp of this. So let's just read the question first. There are 50 patients with lung cancer amongst 25 who are smokers. Okay, so we know that 50 patients who have lung cancer are included in the study. So lung cancer positive, the total would be your 50, right? All right. And then 25 patients are smokers. So meaning 25 smokers are there and 25 non-smokers are also there. So here we have put 25 in both A and C. Great. Now there are 100 patients without lung cancer, amongst which 10 patients are smokers. So here we have total of 100 patients without lung cancer, and then 10 are smokers. We have 90 who are non-smokers. So we have got A, B, C, and D, right? Now A25, B10, C25, and D90. So odds ratio is again 8 times D divided by B times C. So that will give you odds ratio of 9, which is a pretty great result. Okay. Now we talk about relative risk. As I said before, cohort studies, the penultimate letter is again R. So it is relative risk will be used in cohort studies. Also remember that randomized controlled trials are also using relative risk. Okay. So what is the relative risk? It is the risk of developing disease in the exposed group divided by risk of developing disease in the unexposed group. So remember in odds ratio, we were actually comparing between those with disease and without disease. Here we're doing it, dividing it upon the basis of exposure. So we'll be concerning with the rows here, right? Okay. And then the formula is number of exposed people with developed disease divided by total number of people exposed. Number of exposed people who develop disease is A here, and then total number of people with exposure, that is your both this whole row, so A plus B. And here we have number of unexposed people who develop disease, that is your C, and total number of people who are unexposed. So that is your C plus D. So the formula is like this: A divided by A plus B divided by C divided by C plus D. Now that will give you a relative risk. Second, we have another example. So 5 patients who developed stroke out of 10 hypertensive patients. Okay, so there are 10 patients who had hypertension, and then here you have 10 normotensive patients. So here 10 patients who have normotension. Okay, so 5 patients developed stroke. So you put stroke, 5 patients here, and then that leaves you with 5 patients who did not develop stroke. And from this 10, you have 1 who developed stroke, and then 9 who did not. And then again, you got your A, B, C, and D. Then you just use this formula and put all the data, and you'll get 5. Relative risk is 5 here. All right. Now, this is important. So for odds ratio, relative risk, or hazard ratio. So if the value is 1, remember that there is no association. If the value is increasing, it's more than 1 and increasing, meaning that there's an increased association. And if the value is less than 1, there is decreased association. You may ask why? Because all these ratios, whenever you're calculating a ratio, if the number 1 comes up, meaning the numerator and the denominator are both the same. So there is really no difference. So that's why there is no association. And if it's more, then obviously the numerator is greater. And if it's less, then the denominator is greater. Like that, there is increased or decreased association. So whenever you see a case and you have been given a study where they say the odds ratio or the relative risk of 1, then just remember that study is not significant. Okay. Then we have to talk about relative risk reduction. So the definition is it's the proportion of risk in the exposure group after an intervention compared to the risk in non-exposure group. Okay. So it basically is saying how much the risk has been decreased, but in a relative way. Why do I say relative? We'll check it out later when we go through attributable risk. Okay. So the formula is pretty straightforward. Relative risk reduction is simply 1 minus relative risk. Again, we have an example. So 2 out of 10 vaccinated people develop flu and 8 out of 10 unvaccinated people develop flu. Okay, so vaccinated 10 here, 10 vaccinated people, and then 2 developed flu and 8 didn't. And again, 10 unvaccinated, so 8 developed flu and 2 didn't. So the relative risk is 2 upon 10 times 8 upon 10, so that's 0.25. To calculate the relative risk reduction, just simply subtract it from 1. Subtract relative risk from 1, and you'll end up having 0.75. So that is your relative risk reduction. Okay. Now we talk about attributable risk. Now, this is the difference in risk between the exposed and the unexposed group. Okay. So if you're talking about incident risk, so the formula is like this: incidence risk in exposed group minus incidence risk in unexposed group. So you have to basically just subtract. There's no relative thing here. Okay. Again, we go through an example. So 20 patients who develop lung cancer out of 100 smokers. Again, so smokers, 100 smokers, 20 develop lung cancer and 80 didn't. And then 100 non-smokers, and then 5 developed lung cancer, 95 didn't. So the formula is A divided by A plus B minus C divided by C plus D. So 20 upon 100 minus 5 upon 100, that is your 15. So attributable risk is 15. You will see that attributable risk is always bigger than the relative risk. Relative risk, since you're subtracting from 1, so it's usually in fraction, but attributable risk is much bigger. And whenever you're given a study, whenever they are giving the attributable risk, it looks much more impactful because the value is much greater than the relative risk. Okay. Then you can calculate the attributable risk percentage. So it's the proportion of disease incidence among exposed individuals that can be attributed to the risk factor. Okay. So here's the thing. See, here you have 80, total of 100 patients, among which 20 100 smokers and 20 who develop lung cancer. So can you really say that all 20 of them who develop lung cancer, this cancer can be attributed really to the smoking? So that's why you can calculate this attributable risk percentage. Okay, so you calculate it, you have to first calculate the relative risk. The formula is relative risk minus 1 divided by relative risk, and you have to multiply with 100. So again, the same example. Yeah, so the relative risk here is 4. If you calculate it, and then 4 minus 1 time divided by 4 times 100, that is your 75%. All right. Then absolute risk reduction. So it is basically the difference between the risk in the exposure group after an intervention and the risk in the non-exposure group. So here also you're basically subtracting, and whenever you're given any these kinds of questions where you have to calculate the absolute risk reduction or the attributable risk, just remember to subtract the smaller amount from the higher amount. So it usually it will be correct. But if you want to be like really thorough, then just calculate this whole formula and then use this formula to properly calculate the these factors. Okay, so the formula is C divided by C plus D and minus A divided by A plus B. Again, we have the example: 2 out of 10 vaccinated people develop flu and 8 out of 10 unvaccinated people develop flu. So we have the 2/2 table again. And then if you use this data to feed the formula, you'll have 8 upon 10 minus 2/10. So that's your 0.6. All right. That is your absolute risk reduction. All right. Now, this number needed to treat. So whenever you're doing a randomized controlled trial, these number needed to treat and number needed to harm becomes very important. We'll see why. See, the number of individuals that must be treated in a particular time period for one person to benefit from treatment. Okay. So number needed to treat, the formula is 1 divided by absolute risk reduction. So here, the lower the number, the better the treatment. Why? Because, by treating only a small amount of number, one person can benefit from it. So like if the number is, suppose number is 1, you're treating one person and that one person is getting benefited. So basically, the lower the number, the better the treatment. Okay. But whenever you're calculating number needed to treat, you have to have these factors. See, it compares the effects of two intervention in a specific group of people. So you need to have two different groups with specific people with two interventions. You must have a specific outcome. Without this outcome, you won't be able to, calculate this number needed to treat. And you must have a predetermined time. So whenever you have a question that's asking you to calculate number needed to treat, you most probably won't be needing to look at all these things, but it's good to know that these factors must be there whenever you're calculating number needed to treat. And then similarly, we have number needed to harm. Now, number needed to harm is the number of people who must be exposed to a treatment to cause harm to one person who otherwise would not have been harmed. So remember, whenever you're giving someone some drug, there must be some side effects, right? So there must be some harm in giving the drug. So we always do a risk benefit analysis, right? So here we're calculating the number needed to harm because, you have to expose the patients to a treatment to cause harm to one patient. So this number should be very high. Why? Because suppose you're treating 100 patients and then that causes harm to only one patient. That is better than you treating a single patient and causing harm to him, one person. So it's better if the number is higher. So you can calculate it by 1 divided by absolute attributable risk. Okay, the lower the number needed for harm, it's there is more risk for harm, and number needed of harm 1 means that every patient treated is harmed. So the higher the number, the better. All right. Now we talk about sensitivity and specificity. So whenever you're doing some test, there is always some sensitivity and specificity attached to it that are some important attributes of that test. So to calculate sensitivity and specificity, again you need to have this 2x2 table. So let's first discuss this 2x2 table. Okay, so on the top you again have the disease, and on the left side you have the test that you're intending to administer. Okay, so here you have the test positive and also the disease positive. So both of them positive, meaning it's a true positive. Okay, here you have the test negative, test positive, but the disease is negative. So meaning this is a false positive. The test detects there is disease, but actually there is none. Similarly, you have this positive disease, but test is showing negative. So this is a false negative because the person is actually having some disease. Here the disease is negative and test is also negative. So this is true negative. So true positive and true negative is ideal, but then we live in a real world where false positive and false negatives happen also. Okay. So let's just compare sensitivity and specificity. So sensitivity is basically the true positive rate. So you calculate by true positive divided by true positive plus false negative. And the specificity, you have to calculate it by true negative rate. So that is true negative divided by false positive plus true negative. Okay. So in other words, it is sensitivity is proportion of all people with disease who test positive, or the ability of a test to correctly identify those with the disease. Correctly identify those who are disease positive, meaning a true positive. Whereas the specificity is the proportion of all people without disease who test negative, or the ability of a test to correctly identify those without the disease. So correctly identifying those without the disease, meaning a true negative test. Okay. So you have to remember this, that there is inverse relation to false negative when you talk about sensitivity. So it's good for ruling out disease. So whenever you're doing a disease, if there is really low false negative, then you can use this mnemonic. So snout. So if the test is highly sensitive and if it's negative, you can rule out the disease. Why? Because if the test is having really low false negative rates, meaning even if the test is negative, you know it's a true negative, so you can rule out. On the other hand, the specificity is it has some inverse relation with false positive, so good for ruling in a disease. So remember spin. So if the test is highly specific, you can use a positive test to rule in. So what is the rationale again? So you have low false positive if the test is highly specific, right? So meaning that if the person is tested positive, meaning there's a really low chance that it's a false positive. So you can consider using a high specificity test to rule in a certain disease. Okay. So like sensitivity and specificity, you also have positive predictive value and negative predictive value. We're going to use the same table. So let's compare. So in positive predictive value is the probability that a person who has a positive test result actually has the disease. So positive test result actually having the disease. Okay. But on the other hand, the negative predictive value is the probability that a person with a negative test result actually does not have the disease. Does not. Okay. So what is the formula? PPV is true positive upon true positive plus false positive. Okay. Whereas the NPV is your true negative here upon true negative plus false negative. Okay. So you have to remember that PPV increases when there is increased prevalence or the pre-test probability of a test. But NPV varies inversely with prevalence and pre-test probability. So I would urge you to remember it like this. So PPV has a P, prevalence has a P, and then pre-test probability also has some P's. So they all go in the same direction. So whenever the prevalence is increasing, the PPV will increase. With the pre-test probability increasing, the PPV will also increase. But NPV goes the other way around. All right. Okay. So here we have this diagram, this very useful diagram. So suppose this green curve here, this one, they have without disease. So no disease here. And this red curve here with disease. Okay. So let's suppose you're taking this curve A, this line A. So this is the test. Okay. So left side of the test, that is all negative, and right side of the test is all positive. Okay. So just see this this line is intersecting this without disease curve. So the left side is this side, it's fine, it's true negative. But what about this right side? These people do not actually have the disease, but they're being tested as positive. So what does that make? That is the false positive, right? And if we talk about this B, the same one. So this side it's all positive, and the left side is all negative. Okay, so these are the true positives, because on the right side of this B, everybody is being tested positive. But on the left side, these are negative. But remember, these people in the red curve on the left side here, they actually have the disease, but they're being tested as negative. So what are they actually? They're false negative, right? Okay. So this is what happens when you lower the cutoff value. Suppose this dotted line here, you move it towards left, or you move it towards right towards B. What will happen to sensitivity, specificity, PPV, and NPV? So whenever you're lowering the cutoff value, for example, you're moving B towards A. So what will happen? False positive will increase, and then false negative will decrease. So sensitivity and NPV will increase, and specificity and PPV will be decreased. But if you raise the cutoff value, for example, if you're moving A towards B, so what will happen? False negative will be increased and false positive will be decreased. So specificity and positive predictive value will be increased. On the other hand, sensitivity and negative predictive value will be decreased. All right. So how do you remember this one? So just look at it like this. Whenever you're moving towards the right side of this whole diagram, what happens? Your specificity and the positive predictive value is increasing. So whenever you're moving to the right, anything with P is increasing. Whenever you're moving towards the left, anything with N, like sensitivity and NPV, they're all decreasing. Okay, that's one we can remember. Then we talk about likelihood ratio. So there is positive likelihood ratio and then there's negative likelihood ratio. So what is positive likelihood ratio? So for a person that tests positive, it compares the likelihood that the person does or does not have the condition. So in other words, is the probability of positive result in a patient with disorder, that is divided by probability of positive result in patient without disorder. So just remember, positive likelihood ratio only deals with positive result. Okay. So patient with disorder having the positive result divided by patient without disorder having the positive result. So it's basically true positive rate divided by false positive rate. In other way, we know that true positive means it's sensitivity, right? And false positive is 1 minus specificity. So yeah, you have to remember another thing. So sensitivity, okay. So sensitivity is inversely related to your false negative, and specificity is inversely related to your false positive. So 1 minus 1 minus specificity will be your false positive rate, and 1 minus sensitivity will be your false negative rate. So just again, for memorization purposes, you can just remember that false positive goes with specificity and false negative goes with sensitivity. So all the N's cluster together and all the P's cluster together. And just remember, we're talking about false only. So not true negative or true positive. Okay. Yeah. So the formula is sensitivity over 1 minus specificity for positive likelihood ratio. On the other hand, the negative likelihood ratio is for a person that tests negative. You compare the likelihood that the person does or does not have this condition. So for negative likelihood ratio, your all patients must be with negative result. And then you take out the ratio between patient with disorder and patient without disorder. The formula is like false negative rate divided by true negative rate. So 1 minus sensitivity divided by specificity. So what is the purpose of this positive likelihood and negative likelihood ratio? So if the value is really high, when it's positive likelihood ratio, so person who has the condition more likely to test positive than the person who does not. So if the LR plus is more than 10, you can conclude that the test is very highly specific. But in negative likelihood ratio, if the value is less than 1, person who does not have condition more likely to test negative than someone who does. So if the LR minus value is less than 0.1, you can conclude that the test is highly sensitive. Okay. Again, negative likelihood ratio is going with sensitive, and positive likelihood ratio is going with specific. So all the P's and all the N's are clustering together again. So you can use that to remember this. Now talk about accuracy and precision. Now, precision is also known as reliability, whereas accuracy, it's known as validity. So reliability and validity of the test. Both of them, they are actually showing the consistency and the reproducibility of the test, but then precision will increase, decrease. I'm sorry, the precision will increase in the absence of random variation in a test. But on the other hand, the accuracy will increase when there is absence of systematic error or biases. Okay, so you have to remember that whenever there is increased precision, there is decreased standard deviation. So you have to remember that absence of random variation, meaning that standard deviation will become smaller. Okay, and as random variation is decreasing, standard deviation is decreasing, statistical power is also increasing, as these go in the opposite directions. So if precision is increasing, standard deviation will decrease, but statistical power will increase. All right. So here is a diagram showing high and low accuracy and precision. So on the top left here, see, all the values are clustered in the center, okay? And they're really close together. So what does that mean? It has high accuracy and high precision. But look at the right one here. Here, all the values are clustered together, but they're nowhere near the center, meaning the accuracy is really not that great, but the precision is really good, as it is producing like similar results with every test. Okay. On the bottom here, we have high accuracy, since all the values are touching the center or somewhat near the center, but the precision is really low because all the values are not clustered together here. And on this diagram, they're all dispersed. I mean, they're not even close to each other, and they're not even close to the center. So it has really low accuracy and low precision. Now we'll talk about measures of central tendencies. So central tendencies, you have to remember three things. One is mean, one is median, one is mode. So what is mean? Mean is the sum of all data values divided by number of values. We'll go through the example later, but first let's deal with the definition. So middle value of a data set sorted from least to the greatest is your median, and for mode is the most common value. And you have to remember, mean is most affected by outliers. So what is outliers? So outliers are data that is really far from the most of the data. So for example, in this data set, we have 1 1 2 3 3 3 4 5 5. An outlier would be something like 95 or probably 1,000. That would be an outlier. So yeah, mean is mostly affected by outliers, but mode is least affected by outliers. So in this data set, you see, to calculate the mean, you have to calculate the sum of all the data values. So if you add this up, you'll get 27. And 27, then you have the number of values. There are 9 values. So you get the mean of 3. Then what is the median? So you have this data set is already sorted from least to great. So the middle part of this thing, that is your median. So that is your 3. And for the mode, you have to check the most common value. Of all the values, 3 is present 3 times only. So it is the mode. So all the mean, median, and the mode is 3 here. And then you know about standard deviation. It calculates the average difference between each value and the mean. So whenever you get USMLE step 1 exam or step 2 or even step 3 score back, you can see your this standard deviation and then the mean is showed there in your score. So standard deviation is basically calculating how far you are from the mean. So it is denoted by sigma and or SD. Okay. So what is variance? Variance is nothing else except it is the square of average difference between each value and the mean. So you can just square the standard deviation and that will give you the variance of a certain data set. And what is standard error of the mean? So it is estimating the difference between a sample's mean and the true population mean. So whenever you're doing some research, after you're done with the calculations, there is some wiggling room where you can conclude that this the mean can have a range from this to this, because you're accepting the fact that we can make mistakes, right? Or if we with slight variations with every study, the values can become slightly different and end up giving you a different result. So we have this standard error of mean. So to calculate, you have to divide standard deviation with root of n. Okay. So here we talk about distribution. So if you have a symmetrical distribution, you'll see the right side and the left side will be equal, and the mean, median, and mode will lie on the dead center of it. Okay. So if you have a negative skew, look, the tail is pointing towards left. And if you have a positive skew, the tail will be pointing towards right. So let's talk about positive skew. So the tail will be pointing towards right, and then mean would be greater than median, and median would be greater than mode. Okay. But the total opposite thing happened with negative skew. Mean will become the most small value. So mode will be greater than median, and median will be greater than mean. Okay. Here also you have this this graph, and then you may need to calculate the number of areas that is covered by one standard deviation or the two standard deviation. So whenever you're given a problem like this, just remember, you have to remember these three facts: that one standard deviation is covering 68% of this data. Okay. Two standard deviation will cover 95.5% of this data set, and three standard deviation will be covering 99.7% of the data set. So these straightforward questions can come up in step 1 or step 2 or even step 3. So if you remember these three data, you won't have any problem calculating the answer from this. Okay, so I think that sums up the today's discussion. So if anyone have any questions, I'll be happy to answer.
Thank you, Dr. Shourya, for the detailed presentation. And I believe it's going to help so many students preparing for the USMLE Step 1, Step 2 CK, and also Step 3. Yeah, so we have one question. Since you have taken both your USMLE Step 1 and Step 2 exams, so we want to know your take on the volume of the biostatistic questions when compared to Step 1 to Step 2, which was like more, where was biostatistics more present in your exam? Was it on Step 1 or Step 2 CK?
So yeah, I think it differs from people to people, but I'll give you my experience. For Step 1, I had really less amount of biostats in my exam. But when I took Step 2, I had a couple of exams, a couple of questions in every block, apart from the drug ad questions. So I'd say for me personally, the weight of biostats were even greater in Step 2 than in Step 1. And I have not yet taken Step 3, but I have heard that in Step 3, the weight of biostatistical questions are even greater than step 1 and step 2.
Okay, thank you for that. So the other question we have is, which resources do you recommend for biostatistics?
So I myself used First Aid for USMLE. So that is the best resource for step 1 and also step 2 for that matter. And I personally really like the Randy Neal videos they're on YouTube and they're free. You can check them out just a few days before your exam. They will really help you because these videos are very concise, and whenever you're feeling like you don't want to read something, so you can just check out the videos and he'll give you a very brief and very useful summary of the whole thing, whole biostats. So that is really useful. And for step 2, I personally used Amboss question bank for biostats. I think that helped me a lot.
Okay, thank you for that.
Yeah.
So we have one more question. So this question asked, when you are during your dedicated exam, study period for both your exams, when do you think is the right time to review your final biostatistics concepts or formulas for the exam?
So I actually kept biostats for the last during my preparation. When I was doing UWorld, I kept biostats for last because I knew the formulas are going to be volatile and I need to review them before my exam in order to, fully have access to them in my mind. So what I did before my exam, like 1 to 2 days before my exam, I went through the Randy Neal videos, and then I actually went through all the formulas in the first aid, and also in the rapid review section there are some things about biostats. So reviewing those 1 or 2 days before the examination really helped me a lot. So as to you remember those formulas when you're taking the exam.
Yeah, exactly. So just to also say a few points about my experience, you're right. So first aid is really important, even if you are taking step 2 or even step 3. Step 1 first aid is really good because biostatistics is basically similar on all steps, but it becomes more detailed, more long questions as you proceed from step 1, step 2, step 3. So of course, first aid is a key for all steps, and of course, Randy Neal's videos. They're short, and for me, I was reviewing those videos also at the last minute. So it's hard to take in all the concepts of other subjects on top of biostatistics, but if you need that rapid review, also like as you mentioned, Randy Neal videos are really good.
Yeah.
So does anybody have any additional questions before we wrap up?
Doctor, do you mind to take a class on the drug ads question? Like on the step 2, there are big chunks, right? The drug ads, they're really big questions. Can you please help us on those questions? If you have time, please, I'll appreciate.
Sorry, can you repeat that? I could not hear you properly.
Like the drug ad questions on the step 2, they're really huge, right? Yeah, if you can help us on those.
Yeah, sure. Yeah, the drag ad questions are really long, and then I think there's a systematic way to approach them. So yeah, maybe we can go through the drag ad question someday, and I think it will be helpful for all those who are taking step 2. So the important thing is you have to first read the question and then get back to the excerpt that you have to read, because without reading the question, reading the whole excerpt won't give you anything. So it's better to read the question first, so you know properly what to look for in the particular question. And apart from that, all the biostats concepts, like you have to check which data are not really significant. You have to rule those out and look at the significance of each of the data that you are given. Like that, I think you can rule out most of it. But yeah, in my exam, I I think I had 2 drug ad questions, and for both of me, I found them difficult, but then you're given some extra time to solve those. So I kept them for the last, and then I used all my time to solve those drug ads. So that is one strategy that might also help you. And I think Dr. Randy Neal will, I think there's also a video on drug ads, solving drug ads. It might also be helpful if you go through that once. Okay.
Yeah, got it. If you can show us like the strategy that you follow, like the questions are really long, right? So I get really distracted with the information. So if you can show us the approach, how you did it, that would be really helpful.
Okay, we can do this. Maybe we can accumulate some drag ad questions, and then we will go through the questions in another seminar probably. That
Yeah, that would be great.
That will be.
Thank you so much. I appreciate it.
You're welcome.
Yes. So I think that's the plan. Thank you, Dr. Shourya, for dedicating your time. And he's also willing to have part 2 seminar. And we were discussing it actually prior to the webinar. So if that's what our students need, we will be having part 2 webinar mainly focused on the drug ads, and also maybe different, like maybe to solve some sample questions on maybe detailed research like case presentations, cohort, or any other biostatistic questions that were not covered here today. And also one more thing for the drag ads, yeah, you're right. So you will have like additional time, because on the block that's containing the drag ad questions, you won't be having 40 questions, rather you'll be having like 38 questions. So you'll be 2 questions short, where you'll have maybe like few extra minutes to work on your drag ad questions, because they know it's going to take longer time to solve those questions.
Yes. So anyone have any other questions? Let's see. So what time will the webinar be conducted? I think Dr. Metcalfe will share you the details of that webinar in the coming weeks, probably.
Yes, definitely. So we'll see our schedule. We have also other pending webinars coming up, hopefully in March. But if we have some time before that, we can arrange it, or not. Maybe possibly in March, we'll be taking maybe mid or maybe late March, we might be having that webinar. But definitely we'll keep you guys posted on our social medias, on our website, on our LinkedIn, and also Instagram.
Yeah, that's great.
So yeah, since we are almost close to wrapping up the session. Yeah. Okay. Perfect.
Thank you so much, Dr. Shourya. It was a wonderful session. Thank you so much.
Thank you. Thank you for attending. All of you have a very good day.